to welcome everyone to our clinical pharmacology lecture series. It gives me great pleasure to introduce our speaker for today, Dr. Bruce Rubin. Dr. Rubin is a professor and chair emeritus of pediatrics at Virginia Commonwealth University and professor of biomedical engineering at VCU. As a Rhodes Scholar, he trained in biomedical engineering at Oxford University, and then he did his fellowship in pediatric respirology at Sick Kids in Toronto. Dr. Rubin holds an MD and master's in engineering degrees from Tulane and an MBA degree from Wake Forest University Babcock School of Business. He's on the board of the Zona Pediatria Children's Hospital in Guatemala City and a visiting professor at the National Medical University in Western Ukraine. Dr. Rubin received the Forrest Bird Lifetime Scientific Achievement Award and the Jimmy A. Young Medal from the AARC, the Prix Extraordinaire from SIP, and he is a Prix Galien laureate. He holds honorary appointments in 4 medical schools. He's on the editorial board of 10 journals. He has published more than 300, original research papers and holds 10 patents. His research focus is regulation of mucus clearance in health and disease, airway inflammation and immunomodulation, cough, severe asthma, and aerosol delivery of medications. Dr. Rubin is also a magician, a member of the International Brotherhood of Magicians, Order of Merlin, and over the past 35 years has taught medical magic in 45 countries on 5 continents. It gives me great pleasure to have Dr. Rubin here today. We are so grateful to have you on board, Dr. Rubin. So join me in welcoming Dr. Bruce Rubin.
Thank you, Leslie, and it's always a real joy to speak at this group, very much. Please do a magic trick. My magic trick will be finishing on time, Charity. I do, just to put it in context, I do close-up magic. Fair. Thank you. I do close-up magic, which involves stethoscopes, reflex hammers, things that a doctor might have, and part of a small group of medical magicians, but it's been a great deal of fun. So my first trick will be to try and get this to work perfectly. And so let me go ahead and share my screen, which is here. And let's see, there should be this. And so we begin. I'm speaking today about effective aerosol therapy. And as mentioned, as an engineer, I've been particularly interested in aerosol delivery to the lung, as well as mucus clearance out, fluid dynamics, if you will. I am not going to give you any equations today. I have no apparent conflicts of interest related to this presentation. I want to start with a bit of history. The Mudge inhaler, I love this. It was one of the first inhalers. You would nebulize whatever you wish by boiling it within the inhaler, and then it would steam out the top. And I just really like the fact that this was made from a beer stein. But the really first pressurized inhaler was developed in 1858, won the silver prize, should have been the gold, at the Paris Academy of Sciences. And basically, one would pressurize without necessarily heating things, which would then come out through a mesh for inhalation. So to define an aerosol is a group of particles that remain suspended in air because of a low terminal settling velocity. And for a spherical particle, what we refer to as the mass median aerodynamic diameter, and these are going to be the only equations I promise, is related to the diameter divided by, the density divided by the square root of the, diameter divided by the square root of the density. And we also talked not only about the median size, but how widely these are dispersed with geometric standard deviation. So something like a meter dose inhaler has a much narrower GSD, so a greater proportion of the medication gets in compared to, say, a jet nebulizer. And I want to mention that really size matters. Inertial impaction in the oral pharynx with very large particles can deposit them in the back of the throat without inhalation. And this can lead to laryngeal dysfunction and thrush if it's a corticosteroid, swallowing the medication with systemic effects, or loss of drugs if it's broken down in the acid in the stomach. Particle size is important. This is a very old paper out of Canada showing that the increase in pulmonary function as measured by the forced expiratory volume is directly related to particle size. So for particle sizes that are too large to be respirable, you have a very modest increase due to absorption from the stomach. But for particles that are small and to be inhaled, you have a significantly better improvement in pulmonary function. So to deposit an aerosol correctly requires a slow inspiratory flow, a deep inhalation, and a breath hold. I can't emphasize enough the slow flow. Remember, inertia will deposit the particles in the back of the throat. So if somebody is breathing in very quickly, you're going to lose particles to that. The inhalation and the breath hold are important to allow the small particles to settle. As an example, breathing in the same subject, which happened to be me, at 80 liters per minute, deposited the aerosol in the trachea and the proximal airway. And you can see down here, if you can see my pointer, some in the stomach. Breathing in the same aerosol at 30 liters per minute deposits much more in the lung, much less in the trachea. This is another study looking at the deposition of sodium chromoglycate, chromalin, that used to be used, both with patient breathing in very quickly and a patient breathing in much more slowly. And you can see a dramatic five-fold difference in deposition. A child who's screaming and crying will breathe in very quickly with a long and usually loud exhalation, preventing deposition. We've said if a child is upset like this, the best way to deliver the aerosol medication is to look at the child, pour it down the drain, and leave. You'll get the same amount into the child with far less time spent. To give this as an illustration, when a child is calm and not crying, you can see some deposition in the oral pharynx with a nebulization and a good outline of the lungs. When the same child is crying, you get oropharyngeal deposition, esophageal, and stomach deposition with minimal deposition in the lungs. So, corollary to that is aerosol therapy works best if a patient is breathing quietly. And in fact, many years ago, they developed this pillow inhaler that treated you while you slept. It treated all sorts of lung troubles, and only today you can get it at almost half price, $3. Well, some of this has been studied using a 9-month-old cask of the nose, throat, and at this point here, what you see is to be attached various aerosols to look at deposition. And what they showed by measuring the breathing patterns of children that were awake and those that were quietly breathing asleep, there is almost a twofold increase, highly significant increase in the amount of medication that got in using the pattern of the sleeping child. So this is a study done in the Netherlands. Esposito Ferran, who is the principal author, said, "This is great. I'm going to study this in real life." So we went into the Children's Hospital, Sophia Children's Hospital, where children were sleeping quietly, crept up to their bed, and put a mask on their face to see how much would actually get in. And what they found is they had a filter on there, gave budesonide, which you see there, but there were very poor cooperation when the child was awake. They were screaming and hollering. And what that meant was when they were awake, they actually got more than when they were asleep because they woke up with, and 3/4 were distressed, and that screaming prevented any aerosol delivery. This has been obviated somewhat by this soother mask invented in Israel and is marketed by Inspirex. We know that babies are principally nasal breathers, and so what Israel Amarav did was he put in a pacifier to calm the child, to make a better seal on the airway, and to allow nasal breathing. And it actually tripled the amount of medication that could be delivered to the lungs. So let's talk about the different ways of delivering: nebulization, meter dose inhaler, dry powder inhaler. Nebulizers can be given at any age with tidal breathing. You can use them when they're asleep, and I show you as long as the patient doesn't wake up, that's fine. When the patient is sick, you don't need to coordinate breathing. You can give higher doses, but the dose tends to be concentrated as you go down. So the initial amount given is far less. And by the time the child is not cooperating, you end up losing some. No propellant, very little teaching, and you can mix medications, but sometimes the medications aren't compatible, and this can lead to problems. There are significant disadvantages, though. It's less portable and it requires a power source. It takes much more time, generally about 5 to 7 minutes. The equipment needs to be maintained, and I can't emphasize enough cleaning, or you're going to be inhaling things that you shouldn't be. Requires a power source. The medication is more expensive with a metered dose inhaler or a dry powder inhaler because you're giving more, and it usually has very poor efficacy. Better for a vibrating mesh nebulizer, but gives very variable delivery. And the adherence is poorest. And it's poorest because to deliver this, you've got to calm the child, then pull the nebulizer off the shelf, mix the medication and pour it into the cup, put it on, and then hold it to the quiet child's face for 5 to 10 minutes. And nebulizers aren't the same. This looks at the respirable mass, which is defined as 1 to 5 microns mass median aerodynamic diameter, as I mentioned way back. And you can see some of the nebulizers produce a great deal of output, but the amount that's in the respirable zone is very small, much larger particles. Others that seem to produce much less actually deliver more to the lung. Most of these inefficient nebulizers are no longer marketed, and the ones that we're seeing tend to be much more efficient. So the first myth, jet nebulization by albuterol is more effective than giving medication by pressurized metered dose inhaler in the emergency department. This is a study done by Castro Rodriguez, a very famous respirologist out of Columbia, not the medical school, but the country, and was a meta-analysis looking at beta agonists given by metered dose inhaler versus nebulizer for children with wheezing or asthma under 5 years of age. And what they found was beta agonists, albuterol in most cases, by metered dose inhaler and valved holding chamber, and I'll discuss that in a moment, was much more effective in decreasing admission rate and symptom score, both highly significant. Looking at a much larger group of patients, data from 21 trials, including 880 children with mild and moderate, didn't show significant differences in admission rate or peak flow or respiratory rate or development of tremor as a side effect. But what they found was less time in the emergency department. This was done out of Canada, where it's referred to as accident and emergency, with a valved holding chamber. And those children that used this with a nebulizer had greater tremor and a greater heart rate. Looking at this more carefully, studies again out of the Netherlands show lung deposition with a Gret nebulizer in infants is very poor. In children using a mask of age 3 to 6, it's about 6% who have been well trained, about 15% in adults. So let's call that 5 and 15%, and we'll bring this up again in a moment. Dry powder inhalers. Go back to the Abbott's Aero inhaler, where dry powder is dispersed and then inhaled, to more sophisticated, such as the discus, where you have a series of baffles that are sent around and inhaled. Through this point, it's punctured, then through there inhaled, or the turbuhaler. These have no propellants and they're portable. They're very fast, just requiring inhalation. They're breath actuated in that they only give medication when you inhale, unlike the jet nebulizer and potentially the metered dose inhaler. But if you exhale into the dry powder, the humidity from your mouth may actually clot up the mechanism. It requires a bit of a higher inspiratory flow to break down the particles, although the newer ones require a less inspiratory flow. There are dose counters that allow you to see how many doses remain, and it's fairly easy to teach the technique. Put it in your mouth and inhale. And remember, I showed you 5% deposition under the age of 6 and about 10 to 15% over that age. Using a dry powder inhaler, the same group, Sunlin Devaditson, showed almost a 12% inhalation deposition under the age of 6, up to about a 35% in older children and adults. And finally, the pressurized meter dose inhaler. The first was developed in 1956, quite a while ago. And the story goes that Susie was a young girl who had asthma, and her father was a vice president of Riker Labs. Came home and kept complaining that the atomizer, which was then used sort of like delivering perfume, kept leaking in her book bag. Why couldn't Dad and her company make a medication like they made Mom's hairspray? And so they developed the MediHaler. The application to the Food and Drug Administration was under 50 pages, but it was really the first meter dose inhaler, and it worked quite well and has had minimal changes through the years. Advantages are they're portable, small, even with a holding chamber attached. Higher lung deposition compared to nebulization, very fast, inexpensive except in the ED, and the reason being is each one of those canisters has a month's worth of medication. So if you're looking at day by day, the cost is less. In the ED, you're delivering a full month, which is more expensive than nebulization. Hence, many EDs in the US tend to use nebulization. Those in other countries will give the patient the meter dose inhaler as they leave. And it's more effective than most nebulization. There are problems with some suspensions, like inhaled corticosteroids, need to shake the canister. Breathing in too quickly will still deposit in the back of the throat, or exhaling will cause you to lose it. Delaying the actuation to inhalation. All of these things mean it takes a little bit longer to teach how to use this. Adding on the holding chamber is a little bit less portable than the meter dose inhaler alone. And these are things like the Aero chamber. There are many different kinds. They're referred to as valved holding chambers. If you give all the inhalations into the holding chamber, it'll begin to settle and you lose some drug. And it's a little bit more difficult to teach and to learn, so patients may contrive to use it their own way. There are two types. There are those that contain chlorofluorocarbons, which are the older ones, and there are the newer ones containing hydrofluoralkene. The chlorofluorocarbons were phased out a bit because of their effect on the environment. Some of the HFA, hydrofluoralkene carriers, HFA 133A being the most common, will dissolve the medication completely, allowing a smaller particle size. But many of them have exactly the same particle size as a chlorofluorocarbon. So only those that go into solution with this ethanol solvent used for the hydrofluoralkene, and I've given some names there, will have a smaller particle size. Other aerosols are about the same size, regardless of the carrier used. And this shows a few different ones where you have greater deposition with beclomethasone, ciclofenamide, but about the same if you're looking at fluticasone or triamcinolone or budesonide or flunisolide. Smaller particle size improves asthma outcome is a myth. And while the small particle size, usually those under 2.5 microns, are better able to deposit in the small airway, there's really no evidence that this leads to better outcomes. Up to the point of decreasing the mass median aerodynamic diameter less than about 5, there's very little gained. In fact, the smallest particles can sometimes be inhaled, and if you don't wait to allow them to settle, they will be exhaled again. So this looked at a study looking at fluticasone, Flovent, versus extra fine beclomethasone for chronic asthma in adults and children. As you know, the Cochrane Library is a way of developing high quality evidence. And a little throw-out fact, Archie Cochrane was actually a respirologist, was a pulmonologist in Wales. They looked at 9 studies. 2 studies were in children. Study quality was fair, but all were fairly short duration. And they showed there was really no difference between using the extra fine beclomethasone and the larger particle fluticasone when compared at the same dose in these parallel studies. Lung deposition of a meter dose inhaler and always attached to a valve holding chamber is slightly better than what we see with a dry powder inhaler, not significantly so, about 18% for the really small children. And here you see you can go even younger, and up to about 40% for older adolescents. What's interesting, and this is an important point, how much actually deposits on the airway surface. And in this case, God or whatever being rules over us was actually really, really nice. So I showed you that with either a dry powder inhaler, you get increasing amounts by age, and the same with a meter dose inhaler. If you correct this for body weight, which is a pretty good surrogate for lung surface, it all becomes the same. And so what that means is the amount of puffs you give for a 4-year-old or a 3-year-old should be the same as for a 13 or 14-year-old. They're smaller, but less deposits in the airway, and in the end, it's a wash. There are also more newer delivery systems. There are soft mist inhalers like the Respimat. I'm going to talk a bit about vibrating mesh inhalers, expensive breath-controlled and smart nebulizers that aren't used generally for giving things like albuterol corticosteroids, but other medications. And now we're delivering a great deal through the airway, everything from growth hormone to medications for systemic absorption and treating hypertension. So these small volume liquid inhalers, like the Respimat or the soft mist inhaler, I've got a diagram here. This is propellant free, so you don't have to worry about propellants producing any adverse effects on either the patient or the environment, like the fluorocarbons. It's breath actuated. The spring only goes when it measures an inspiratory flow, and it produces a very slow flow relative to a meter dose inhaler, what's called a soft mist, making it easier to inhale. This looks at tiotropium administered either at 5 micrograms using a soft mist inhaler, and you get roughly the same deposition as giving threefold in a handinhaler. The device is disposable. It's produced by a spring. The aerosol velocity is very slow, 10 meters per second, and it's been currently used for beta agonists and cholinergics. This soft mist makes it easier to coordinate, gives greater lung delivery, but the dosing chamber is small, so there are only certain medications you can give, and you still need to coordinate inhalation and actuation. Getting more expensive, but also more usable, is these vibrating mesh nebulizer. This has a piezo element, in other words, pressure allows flow, vibrating a mesh or horn, and you can see these horns there, and these horns in the mesh that allow very specific fine particles to exit. These are small, they're portable, they're battery operated, they tend to deliver medications fast, and you can load them with a higher dose. Very effective. The problem is you can't put everything in there. Viscous drugs, and in this case, a patient was using hypertonic saline to treat their cystic fibrosis, can completely cake this. And since it's silent, you won't know that it's not delivering medication. Also, if you have complexes like a drug carrier, you can get disruption. The pores, as I showed, could be clogged by suspensions, and it's difficult to clean. If you handle the mesh inappropriately, you can damage it. And then there's going to the next step, adaptive aerosol delivery. Very useful for more expensive medication. It's pre-programmed by an inhalation dose, and it measures how the patient breathes over a series of breaths, and then delivers almost all the medication at the inhalation. So as the patient continues to inhale, it goes deeper into the lungs, and then as they exhale, you lose less. This feedback also gives information to the patient that they've inhaled the medication, so they know that they're inhaling deeply enough, and it also logs the use. Expensive, but effective for very expensive medications. Small volume liquid inhalers. This is again, a very expensive way of delivering medication, but it usually delivers about 3/4 of the dose. This has been used for things like growth hormone to obviate the need for injections, and it's been used for things like insulin. And what we can see, this is krypton, which is a gas that outlines how much of the lung is actually being ventilated. This is a healthy individual. I happen to know who it was. And this is using one of these inhalers using a medication, and you can see deposition is excellent. And there are breath-controlled nebulizers, a little bit less expensive, but only give medication when you inhale. It allows more precise dosing, better dispersion pattern. You can use larger particles when you give a slow inhalation. Remember, I talked about mass median aerodynamic diameter and velocity, allowing it to deposit on the oral pharynx as opposed to distally. Very low residual volumes, but these are really expensive. Costs are absorbed with expensive medications, such as growth hormone, and the mesh itself can be clogged. An example of this is Akita. This limits inspiratory flow quite low. Larger particles can get to the distant lung, bypassing areas of obstruction. These are images from patients with cystic fibrosis who are inhaling an expensive aerosol antibiotic. I believe it was colistin at this time, deeper into the airway, and you can see pretty good deposition with only a little bit swallowed. That outlines the stomach. And then interestingly enough, you can engineer the particle itself. So the delivery device is really simple. It just punctures this capsule when you inhale, but the particles themselves look like wiffle balls. These are hollow and porous. And what's important is that because there's very little surface contact, these tend not to agglomerate and produce a larger particle size. This was a study looking at tobramycin and looking at giving an inhalation as opposed to the nebulization. You got much more delivered into the lung. And now this actually comes from our group using a HandiHaler and a drug that is extremely small, but as it enters the airway, it grows to allow deposition using even a relatively quick inhalation, and that growth allows deposition principally within the lower airway. And we've looked at this for medications like insulin and now medications being used to treat asthma. You can also deliver systemic drugs by aerosol. The considerations are because this has to be so carefully engineered. We usually look at an expensive medication that isn't broken down with inhalation, that's safe by inhalation and not broken down at the airway, and you really want absorption and systemic effects. Growth hormone, where giving injections continuously to small children can be problematic, or even to adults who are needle phobic. Insulin, where you want delivery to the airway, but deep deposition for patients, again, who are needle phobic. So let's talk about diabetes, because this is the one that's been most studied. It affects over 200 million people globally. Insulin has a relatively narrow therapeutic index. And by the way, it was first given by Aerosol in 1925, Über Inhalation von Aerosol in German. And it did not work extremely well. The particle was big, it was broken down. So although it did reduce blood sugar, it wasn't very effective. This, as you know, was just a few years after the Canadian scientists Banting, Best, and McLeod isolated insulin. Human growth hormone has also been developed, and it's particularly of interest to pediatricians because so many children are needle phobic. So I just want to talk about the role of adherence in using medication and delivery and such. Asthma resistant to therapy usually means resistance to taking the medication, which is why we talked about giving medication, say, by aerosol rather than injection. And I just want to say compliance is when the patient does what you tell them, since you are the adult in the room. Adherence is where you have a patient do what's right because they know they're supposed to do it. And contrivance is they do what they want when they want. Talk to the hand, the lungs aren't listening. So non-adherent patients cannot necessarily be recognized by healthcare providers. These were pediatric asthma patients, and those that looked about to suggested their adherence, up to 100% given twice a daily or 3 times daily, and yet actual adherence was significantly less. And for 4 times a day, hey, 3/4 said I'm adhering, taking it every day. but the actual adherence measured by taking it the same amount every day was less than 20%. And what does this mean? Well, this is a study of 29 children, and they gave them a metered dose inhaler that had this big contraption on the outside called Cronlog. And it said, this will measure every time you take the medication and record the day and the time. So they knew they were being recorded. And even knowing that, only about half the study days had full adherence with very variable patterns. There were a number of patients that would stop taking their medications or only take their medications once a day. But on the way to the doctor's office, there would suddenly be 30 or 40 inhalations, what we called elevator dumping, and adherence or compliance was greater in the weeks after clinic. And what does this mean? This is a study out of Canada. Sammy Swissa looked at the group in Manitoba. And Manitoba is interesting. You know, medications are almost all provided in Canada as part of universal health. Interesting, some of the smaller provinces actually measure when the patient fills the medication and records this. And Manitoba and Saskatchewan are two such provinces out in the West that when the patient comes in and fills their medication, this is recorded in a central database. And this looked at adults and the risk of death from asthma. And they found those patients that never filled their inhaler had, no surprise, a much greater risk. Only filling 50%, half the months, dramatically reduced this. And of course, filling all of it reduced it even more. Now, this doesn't tell you they're using it or using it appropriately, but this is a surrogate. So let's talk about using it and using it appropriately. This was an old study where patients had an electronic counter, as I showed you before, on the outside that were knowing that they were using it, and a diary card. And they were taking inhaled corticosteroids for their asthma. These were very severely ill adult subjects, patients. And those on the diary said, hey, 100% adherence, some even more, took it every day exactly as prescribed. This Cronlog on the outside said only about 60% actually took the medications daily, and only about 30% took them appropriately 3 times a day. And what did this mean? Well, 8 of these 24 patients had a breakthrough in asthma requiring oral corticosteroids, and their mean adherence was only 14%. Those severe asthmatics, and then this was measured over a 1-year period, who had no requirement for oral steroids, they had about 68% adherence. So yes, taking medications, adhering is as important as the way you're delivering it. So our challenge is to develop foolproof, efficient, low-cost, portable, and safe aerosol delivery devices. And our challenge is foolproof patients. I thank one of my colleagues, Hannes Feldhaber from Switzerland, who gave me this image specifically for this medication. He's also an aerosol scientist, of his son Henry not being using the device appropriately. And with this, I thank you, and I'll be happy to answer any questions. And you can unmute, I believe, if you're muted.
Yes. Hi, Dr. Rubin. Thank you so much. Fantastic presentation, and you worked your magic. You were done well within time. So
I didn't want people to fall asleep.
no,
So,
no, this fantastic presentation. I think we're all every time you come and are part of this lecture series, we're all taken by the work and the caliber of work that you do. So thank you for being with us today.
and Leslie and I will share my slides with the group. You're more than able to share them. And if there are secondary questions, please go ahead and contact me. I'm an old semi-retired dude, and I'm pretty good at answering questions.
Thank you so much. So I guess what we'll do is we'll just jump into our Q&A session. Just for the our audience, if you have a question, please feel free to go ahead and put them into our Q&A box, or feel free to put them in the chat. You definitely have some comments coming in, so
Super.
uh, just want to read through some of that, about your slides, your wonderful slides, and if if you have contact information, Dr. Rubin, I'm sure.
Yes, I think I put that on the first slide. If I didn't, Leslie Ann can share that with you. Let me go back to my first slide. And no, it isn't. So you can either write it down or she will share it. It is BKRUBIN, BKRubin at outlook.com. And I can put it in the chat as well.
Awesome. Thank you. So let's jump right in. Remember, audience, please feel free to put in your questions and we'll do our best to get to all of them. But I think with our time, we will have a good amount of time to have a really great discussion. So first comment is excellent presentation. Might you know what the concerns are for oropharynx deposition are in the context of upper airway targeted DDS? I guess they're looking for upper versus pulmonary
Brilliant.
differences.
Yeah. Upper airway deposition or pharyngeal deposition can produce a few problems. One is you're going to swallow the medication, more likely to get systemic absorption and systemic effects. So for patients taking albuterol, you're more likely to get tremor. You're more likely to get things associated with taking albuterol, hypokalemia. The second is medications can be broken down in the stomach. And so delivering it with deposition in the oropharynx and swallowing it, you may get loss of medication. And this is the case we see with the difference between aerosol delivery by nebulization and metered dose inhaler. And the third is some medications can produce side effects in the oropharynx. Notoriously, corticosteroids are associated with oropharyngeal thrush if you have deposition there. So it's loss of medications and loss of effect, systemic absorption and systemic effect, breakdown in the stomach, or local side effects.
Wonderful. Just to kind of piggyback off that, Dr. Boone, what do you think, I guess like what device, design feature might most strongly influence, deposition or particle size? What do I guess with emerging technology, just curious to where you think we should be, heading to improve, delivery.
The design feature that is most critical is the patient. And so education, the things that you will be doing are critical. These drugs are too often administered or given to the patient without significant training. Training should be part of seeing the patient and coming back regardless of what they get. So yes, you can get good, efficient nebulization even with a metered dose inhaler and no holding chamber. But the patient has to learn, say, to inhale slowly and deeply with a breath hold and to coordinate. Some of this is obviated or reduced using holding chamber, but each of these require some training. Again, the more effective medications for deep delivery, the more effective delivery devices tend to be more expensive and tend to be only dispensed for more expensive medications. We've gotten much better. Some of the newer delivery devices, such as the mesh nebulizers, are very fast, very efficient, very quiet. It also depends on what the patient is doing. If you're going to give somebody a nebulizer and they know how to use it, but they're traveling and they are phobic of getting on an airplane and they start having asthma and they look for an outlet, and every single outlet in that part of the airport is plugged in by businessmen who are recharging their phones, they're going to have difficulty. So a lot of this depends on the circumstance.
Wonderful. I just have a quick comment about their cartoon, nice little cartoon. It reminds them of Mannequin PIs in Brussels. So thank you for that.
Sure.
I wanted to ask you, you seem, you do have a lot of international influence and appointments outside of the US. And I kind of wanted to ask you just kind of like, what you're seeing, internationally in terms of aerosol devices, any improvements that are being made internationally that we're unaware of, whether it's home use or hospital use?
There are two actually societies that are devoted to aerosol therapy. There's the American Association of Aerosol Therapy, which is actually international, that is more device oriented. And there's ISAM. I'm a member of their board, which is the International Society of Aerosols in Medicine. that includes both clinicians as well as device manufacturers. And there are all sorts of things. The real effort has been developing effective device for expensive medications, better devices for systemic delivery, things like growth hormone and insulin, better devices for delivering to very small children. And there are now devices that are able to deliver good aerosol medication nasally to infants. As you recall from earlier, I think you've learned that infants are preferential nose breathers. I showed you MRAV's device with the soother mask built in, but even developing devices that go directly into the nose. So there's a huge amount. There are studies. Um, so there are a variety of ways to obviate that. Some of them have trickled down to even the less expensive medications and devices. So we're seeing more effective dry powder that require less flow to inhale. We're seeing holding chambers that are more portable. Even things like those wiffle balls I showed you that are becoming less expensive. There's a whole group. I can tell you at our international society meetings, there are probably 40 or 50 people trying to sell different types of new aerosol devices that require less patient learning, less cooperation. But the bottom line is if you don't put the drug in and you don't put it in your mouth or your nose and you don't use it, you ain't getting anywhere. So adherence, 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 education is by far and away the most important part of all of this. What we really need is a device that will jump into the patient's mouth and stay there until they actually use it. Kind of Harry Potter-esque.
Yeah. That was going to be like my next follow-up because, I think the biggest thing is like, how do we improve adherence, and dosing accuracy? Do you think like maybe AI or any kind of like digital monitoring or digital strategies might help? Um,
Part of it, what we have done though, is you can have a fall in your lung function without recognizing it. And so when we've treated patients with asthma, before going home, we'll measure their lung function. And it still is probably depressed. You don't send somebody home with perfect lung function. And then we tell them, when you come back to clinic in 2 to 4 weeks, we're going to measure your lung function again. And if you've been using the medication properly, effectively, inhaling it the right way, you should be normal or near normal. And when they come back, if it's just the same, he said, let's go ahead and review because we think you may not be getting the medication in properly. There are medications, there are ways that have alarms that let you know when the patient is inhaling at an appropriate flow or too quickly or too slowly, such as that Akita device where you get visual feedback for depositing medication. But that's more for depositing things like insulin in the deep airway or growth hormone, which is now being delivered by aerosol. For inexpensive medications, it's education, 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 including when the patient returns to clinic, have them bring their medication with them, ensure that they're filling the medication at the pharmacy, and then have them show you how they use it.
yeah, I mean, I'm so glad that you mentioned just like partnering with other, areas of healthcare, right? Going to the pharmacy and having them, you know, um, really kind of invest in also these patients therapy, making sure they know how to use them. So I think it's a lot of moving parts, right, to making sure that these aerosol therapies are effective. We have a really interesting question, and I don't know if we've talked a lot about newborns and preterm babies. So
Ah,
yeah, they want to know if it says it appears that the success of inhalation is contingent or inhalation therapeutic, excuse me, is contingent to good chemistry and device combinations. Well, what do you think is like what is state of the art for newborns, including preterm babies?
fantastic question. I've actually a whole series of slides that I didn't include there. So Aerogen has developed a nasal delivery device. Remember, infants are primarily nasal breathers. That is very similar to what we're seeing with nasal ventilation that will trigger on inhalation only and can be used with usually meter dose inhalers or with jet nebulization using ultrafine particles. Um, there's also for patients that will not tolerate this, Amrov, my colleague that developed the soother mask, has developed a hood delivery device that gets some into the child. Um, this is when you're having to deliver oxygen and you don't want to interrupt the flow. There are also devices that allow you to deliver this triggered on babies' inhalation only. And of course, for babies that are intubated and ventilated, there are devices that allow an ultrafine particle to bypass that. This is a really active area of study. Um, and again, the question is, what medications do you give? There's very limited information that suggests albuterol has any effect whatsoever in the young child. They don't get bronchospasm. They don't have that muscle. So what are we delivering to these small babies? Potentially growth hormone, certainly antibiotics when they have airway infection. And there are a variety of ways of delivering aerosol, tobramycin or colistin, uh, triggering on inhalation. These use some of these fancier devices that I showed before, recognizing that their inspiratory flow is lower, but it's faster. So you really want to get particles past that nasal obstruction.
Wonderful. Thank you, Dr. Rubin. Again, another question to piggyback off of what you mentioned, the delivery of, growth hormone and even insulin. What do you think about manufacturers trying to deliver biologics into the lungs? I'll even add another one, biologics, but also gene therapies. What do you think that's moving to?
So gene therapy is already well advanced, and that's principally for airway diseases.
Mhm.
So gene therapy for cystic fibrosis is delivered by aerosol, and a lot of that determines the particle size, the inspiratory flow. So you're really depositing it down into the lower airway, and that's well advanced. Um, Delivering systemic gene therapy, human growth hormone, is also being studied. The What you need to know is that gene therapy is expensive, and you want something that will deposit into the distal airway, the acinus, to allow inhalation. So you need to be able to trigger inhalation with a particle size and a velocity that will get down there. You need to be sure that you're not giving medication to somebody that has lost a lot of their distal airway because of infection, inflammation, or even sedation. So giving it actively may make a difference, particularly with small children. You want to make sure that what you're delivering isn't inflammatory to the airway and also isn't broken down at the airway surface. Remember, the airway surface is there to defend against proteins, and all of these are proteins. So the steps are first ensuring that it's compatible with the airway, ensuring that it can get through or past the mucus layer into the sinus, ensuring that it can be delivered in a size small enough and a flow low enough without breaking down the particles, remembering some of these peptides are rather large and fragile. And so this is advanced principally for growth hormone and for insulin. You also want to be sure that you're developing this for a large enough number of subjects, patients, such as insulin, that will be commercially viable, and also for a group of patients that are really needle phobic, such as growth hormone for small children. So there are probably a dozen companies in this field, and I find it super exciting.
Awesome. Well, I think this, puts us in a good place for our last and final question. Where do you see, the biggest innovation being made in aerosol therapy, perhaps in the next 5 or 10 years? Really just want to get your, perspective on future directions.
Wow. Anything that will improve adherence, making sure that the patient takes the medication. Basically, I mean, the biggest obstacle right now isn't necessarily the devices. All that we've come up with, the engineers have come up with some brilliant devices. The device that is least effective is the patient actually using the medication and taking the medication. Harry Potter-esque, you'd really want a device that screams at the patient until they take it. Some sort of reminder, some sort of way that if the patient feels well and they can skip it, it reminds them that they can't. We've discovered that of all the medications out there, the one that there is greatest adherence to are birth control pills, because missing them has such a significant outcome. We would like to be able to develop ways that patients will see their inhalation in a way that will allow them to take it on a regular basis. Again, I told you for asthma, you can get a fairly significant drop in lung function without perceiving it, particularly for patients with chronic disease. They have blunted perception. So finding a way to improve adherence is probably the most important thing we need to do. That is the biggest blockade to medication.
Wonderful. Thank you, Dr. Rubin. This has been an excellent and fantastic session, wonderful presentation, and I think just an even better Q&A. We had some really great questions, and thank you for really addressing them all with such a comprehensive, response to each. So thank you for being here today.
And I'm very happy to address any questions sent afterwards. If you'll go ahead and send those to Leslie Ann, I can go ahead and respond and she can make those questions available. I know as soon as we get off this thing, 3 or 4 questions come up.
Yeah, I'll definitely make sure they come to you. So thank you for your willingness to follow up. I really appreciate it.
All righty. Live
All
long and
right.
prosper.
Well, thank you to our wonderful speaker, and thank you to our wonderful engaged audience for being here today. Just a quick reminder, our next talk is March 18th, given by Dr. Robert Choi of PATH. The talk is entitled Development of Microarray Patches for Delivery of Pediatric Antiretroviral Therapeutics. So again, thank you, Dr. Rubin, a fantastic, amazing talk. And I hope you all have a great rest of your day.
Thanks, Leslie Ann. And thanks everybody for staying for the whole thing.